Okay, so today we have Dr. Christy Soji, who is a board certified clinical geropsychologist working in geriatric primary care and providing consultative services to contract nursing homes. She obtained a master's degree from Wake Forest University and a doctorate degree from the University of Alabama, Tuscaloosa, with a concentration in geropsychology. She then completed a geropsychology internship and fellowship at South Texas Veterans Healthcare System. She has been involved with training in the VA for the past 6 years as a preceptor, supervisor, and assistant training director. Clinical areas of interest include neuropsychology, incapacity evaluation, behavioral interventions, caregiver support for challenging behaviors in the context of dementia, and end-of-life intervention. Dr. Soji is the primary supervisor for the geropsychology residency and a member of the postdoctoral training committee. Outside of work, Dr. Soji loves being a mother and partner, spending time with family, friends, cooking, crafting, reading, and taking bar classes.
Thank you, Laura Madeline.
Thank you. Can you all hear me okay?
Yes.
Yes. Okay, perfect. Well, thank you so much for inviting me to speak today. I noticed when I was looking at my calendar that this is scheduled until I think 12:15, and I had planned, yeah.
It goes till 12 and I just leave the room open till 12:15 because sometimes there's lingering conversations with some of our partners afterwards or so.
Okay. Okay, good. I was a little worried because I only planned for about a 50-minute presentation with time for questions, but that makes me feel better.
That's perfect. Yes.
Okay. And excuse me, whenever I present, I think you can see my screen, my title slide.
Mm-hmm.
Okay. Will you just holler if it switches over to my notes slides, because sometimes I don't know what I do that makes it switch over, but just so I know you're always seeing the slide, that the big slides you can read.
I am happy to monitor the chat. Can people ask questions in the chat
Yeah, absolutely.
So I'll monitor the chat and I'll let you know if there ends up being a slide that has your notes on it as well.
Okay.
What should I call you? Dr. Soji, Dr. Christy, Dr. Christy Soji? What do you like? What do you prefer?
Christy is fine. You can just call me Christy.
Thank you so much.
Yeah, of course. And I'm happy to pause for discussion too. So, if questions come up, feel free to interrupt me and we can chat right then. So I'll go ahead and get started. I don't have any disclosures other than the fact that the views and content that I am presenting are my own. They're not a reflection of the official policy or position of the VA or any agency of the government. And so our learning objectives, what I'd really like to do is start just simple by exploring the definition of dementia, talking about the different types of dementia, causes and symptoms. And then I have a few slides talking about dementia and the veteran population specifically. And then really diving a little deeper into some of the risk factors that are relevant to the veteran population. And then the kind of second half of the talk, I really want to spend some time addressing end-of-life interventions that are helpful from a behavioral standpoint. And a lot of these interventions are not just end-of-life interventions. They can be helpful throughout the dementia process. So what is dementia? If you all are willing, I would love to hear if anyone wants to try giving me a definition of dementia or just describing dementia, your experience with dementia. Feel free to take yourself off of mute.
I think of it as cognitive decline that also impacts not just kind of our executive functioning, but our remove some inhibitions and sometimes the things that we wouldn't allow start to surface.
Mm-hmm. Very good. Anybody else? Anything you'd add? Okay. So on this slide, you'll see a bunch of different types of dementia listed. So dementia is really an umbrella term, which means that it's this overarching term. And then underneath that are all of the different types of dementia. A lot of times when you're working with folks who are just out in the community, who don't, necessarily work in the field of geriatrics, they equate dementia with Alzheimer's disease. But that's just one type. It is the most common type, but there are lots of other types of dementia. And you are absolutely correct. So it is definitely something that affects your cognition, your cognitive functioning, and it can impact all different types of functioning. So it's not just memory. It could be attention, your executive functioning, your ability to learn new information, your language abilities. So all of our different domains of cognition can be impacted. And it really impacts the whole person. So not just their brain activity and how they're thinking, but how they're speaking, how they feel, how they perceive the world, and also how they behave. And so I'm not going to go through each of these in a lot of detail. I just want to touch on a couple of the kind of more common types of dementia. So Alzheimer's, we've already talked about, is the most common, and that's the one that, memory and language are usually most impacted. So when you think about rapid forgetting, vascular dementia is also very common and one that I see all of the time in a veteran population. And so vascular dementia is dementia caused by your heart health. So as healthy as your heart is, that's going to be reflected in your brain functioning. So when you have risk factors like diabetes or high blood pressure or heart disease, those can lead to some of your brain tissue being damaged, either with major strokes or some of those tiny baby strokes that they can see on imaging, TIAs and things like that. And over time, those can build up and cause some damage. And then there's other ones listed here that you've probably heard of, FTD. Usually when people think of FTD, they think of kind of the more challenging behaviors, so lots of disinhibition, sometimes a more sexual behaviors, sexually inappropriate behaviors. You can also have dementia from substance use, from a traumatic brain injury, from Parkinson's disease. So lots of different types of dementia. And I wanted to spend a minute just talking about what I do when I'm first meeting with someone and trying to determine if they meet criteria for a dementia diagnosis. So we do typically define dementia as a significant decline in cognitive functioning from where they were at baseline. And it's also associated with a decrease in their functional ability. So things like paying bills or being able to manage their medications effectively, those are things that can start to be impacted when someone is suffering from a dementia diagnosis. And so when I first meet with them, typically what I'm going to want to do is an interview with the patient and with a collateral source. I'm wondering if anyone can speak to why it might be important for a collateral source to be involved in the interview.
It's unreliable reporting. They might say something with confidence that's not true at all.
Yeah, absolutely. Anything else you can think of?
I just like to say, to verify the accuracy of the information, if you forget that you don't know how to brush your teeth, you may think you're brushing your teeth, but without a person that's there to see, are you really, putting toothbrush on your comb? It's helpful to have a second person verify the information.
Yes, exactly. That lack of insight. Sometimes I'll meet with folks who I go through my entire interview about different deficits they might have, and it's no to everything, then I talk to wife and it's yes for everything with lots of details about where they're struggling. So it's really, really helpful to have a collateral. And so I'm asking about their cognition and trouble with thinking, but I also need to gather information about just their day-to-day functioning. So basic ADLs like bathing, dressing, grooming, feeding themselves, transfers, and then also those more complex activities like paying bills, managing medications, and medical appointments. And then I usually do like to do some testing. Some folks can only endure about 30 minutes, and so we'll do just brief testing. And some we can do more of a kind of a full neuropsychological evaluation. But that's another really helpful piece for diagnosis. And so there in the geropsychology world, there are two main diagnoses or categories that we talk about. And so I wanted to review both of those with you. So we would have kind of common terminology as we're talking. So a major neurocognitive disorder is what we think of as dementia. It's where there's a significant decline in their functioning from their premorbid level in one or more domain. And in addition to that, to meet criteria for a dementia diagnosis, the deficits are also interfering with their ability to do those activities of daily living. And so at a minimum, they're requiring some assistance with the IADLs, so bill paying medications. And then in more severe cases, or as the disease progresses, we start to see that they're needing assistance with the basic ADLs like bathing and dressing. And then a mild neurocognitive disorder, this is what was previously called mild cognitive impairment, or MCI. The difference between this and the major neurocognitive disorder is that there is decline. It's usually more modest decline, so not quite as severe. And there's not impairment in their ability to function. So they're still able to do all of those ADLs and IADLs. They may have some compensatory strategies that are helping them. So for example, I saw a gentleman a few weeks ago who he did have, some moderate cognitive impairment, but he had strategies in place and was still managing all of his ADLs and IDLs independently with those strategies. So he fit more into this mild neurocognitive disorder. And then in geriatrics, we often talk about the rule of thirds for this category for mild neurocognitive disorder. And what that is referring to is that about a third of folks who have an MCI diagnosis will stay the same. About a third will actually get better. So thinking about people who, perhaps this neurocognitive disorder is due to mood or sleep or some other factor that we can treat and improve. And then about a third do go on to develop dementia or a major neurocognitive disorder. And if someone has what's called an amnestic profile, where that rapid forgetting, the memory is the primary concern, they're more likely to develop a major neurocognitive disorder. Okay. This one, it's a little small, so I'm sorry if it's harder to read. I wanted to just share this table because it does show some of the changes in behaviors that you might see in folks who have dementia at the different stages. So just to talk about a few of them, in the early stages, there may be some of that difficulty with initiating, more reliance on routine and structure. So some of that like agitation or confusion when things are not how they're expecting it to be when the schedule changes, but they're still fairly independent in the early stages. And then in moderate or middle stages, you'll notice that conversations are more brief, more vague, some more forgetfulness is likely, or just increasing difficulty with cognition. And then in the severe stages, confusion increases, their ability to converse is minimal. And a lot of times at this stage, we're seeing folks who are, wheelchair bound or bed bound. Okay. I actually do a whole talk on this one slide, but I wanted to include it just to give you all a little taste of it, and have a brief discussion. So one of the things that I'm really interested in is the challenging behaviors that can come up when we're working with someone who has dementia. The behaviors that you'll see, as I'm sure you all have experienced too, they're really variable. I'm sorry, did someone have a question? Okay, sorry. I thought I heard something. So the behaviors are really variable, both across individuals, but also across time. So someone may be exhibiting a challenging behavior that then kind of extinguishes, and then a new one pops up. So a lot of flexibility, I think, is important when you're working with challenging behaviors. One of the things that can be really frustrating for folks is confabulation, which is often associated with alcohol dementia. And that's when the person's memory, there are gaps in their memory. And so to kind of cover up that the memory has been lost, their brain just fills in information. It can be made up information or misinterpreted or distorted information, but they're kind of making up this story. And so that's really frustrating because folks will think that they're lying intentionally. And it's not the case. They're just trying to kind of make up for that memory deficit. And then we talked briefly about FTD and how you can see more of the impulsive or disinhibited behaviors, more apathy, and inappropriate social behavior. So maybe they're not as tactful as they used to be. They may not seem to have empathy for others or be able to connect in that way. We do see hypersexuality, neglecting their hygiene, and sometimes some really repetitive behaviors like calling out repetitively. And I think that, when we face a challenging behavior, it's really helpful to sort of play detective and really pick apart the behavior. So thinking about when it happens, where it happens, who is around when that behavior happens, and then thinking through whether or not any of those factors can be changed. And our reactions are another piece of that. So our reaction to these challenging behaviors, it's either going to reinforce it and keep the behavior going, or it'll help reduce the behavior and extinguish it. So an example that I think is helpful here is, there's someone who's who really gets scared and agitated when someone comes in to provide pericare. And in reaction to the person being scared and agitated, the caregiver is becoming frustrated and raises their voice. The person with dementia gets more scared and more agitated. And so it kind of is this negative loop and just keeps going. On the other hand, if we can figure out what it is that's causing them to be scared and agitated and try to modify those things, we may be able to reduce the behavior. So can the caregiver react in a more neutral way and be sure that they're keeping their voice very neutral? Because we know folks with dementia will look to nonverbals to try and figure out what's going on. Do they need to be oriented to what's happening? Do they need more instruction or simpler instruction? And so I think, the environment is very important, and also just tolerance for the behaviors, knowing that it's not intentional. When we see challenging behaviors, they're really an expression of some type of need that the person has, that they just aren't able to express in another way. Okay, let me pause there for just a second and see if there are any questions before I move on.
There's nothing in the chat right now.
Okay.
Thank
Perfect.
you for your thorough explanation, though. This is really helpful.
Oh, of course, of course. Okay, so I wanted to shift just a little and talk about dementia in the context of working with veterans. Um, so there are a couple of risk factors that are unique to our veteran population that are also associated with dementia. So according to the CDC, there are certain groups that are more likely to sustain a TBI or a traumatic brain injury, and veterans are one of those groups. And so it was reported that over 450,000 service members were diagnosed with a traumatic brain injury in a 20-year time span. So that's quite a few. And while there's more research needed, and you'll hear me say that a lot in this talk, we can definitely use more research in a lot of these areas. There is some evidence that if you suffer a TBI, that increases your risk of developing a major neurocognitive disorder. And there's also, just as a side note, in the DSM, which is sort of like the Bible for psychologists, there is a dementia due to TBI. So someone can sustain a TBI that's severe enough, excuse me, that their cognition has significantly declined and it's impacting their functioning. And then there's also been some research that was interesting showing that in post 9/11 vets, sustaining a TBI actually increased the risk of developing early onset dementia. So another factor that can play a role in cognitive impairment is your mental health, of course. So overall, what we see in the military population is higher rates of psychiatric disorders than in the civilian population. And there is some evidence that certain mood disorders, like depression, anxiety, and PTSD, increase the risk of developing dementia. And it's also important to think about the fact that dementia and mood disorders are commonly co-occurring. And so that can really make the assessment process challenging, and the treatment process challenging. So we're trying to kind of tease apart if the impairments we're seeing, are they due to mood? Are they due to an actual neurodegenerative process? Is it both? And so it can be really difficult to try to parse those things out. Okay. And then the last one I wanted to
Can I ask
talk
a
about.
quick question? There's some
Uh-huh.
chat. What is a good resource or handout for family caregivers, normalizing dementia behaviors and offering guidance?
So there are, if you look on the NIA, NIH website, they have a wealth of resources. Some are pretty general about, just about dementia. They have some specific to Alzheimer's or FTD. Some are, specific to caregivers, like a caregiver handbook. And then they have certain topics too, like sleep in older adults and pain in older adults. So they have all of these resources and you can order them for free. So you can either download an electronic copy or you can order print materials. So I have, shelves of materials in my office and you can hand those out. And I think it's helpful. What I typically do is I kind of review it with them, and then they get to take that home and kind of have time to digest everything and go back to it. So I would recommend starting there. That's usually a really good resource. Great
Can you say
question.
the name of the resource again? Is that the one that was shared by Stephanie?
I'm not sure. Is it in the chat?
Yeah, she put veteran specific resource for dementia in the chat. But what did you say it was?
It's NIA, NIH, National Institute of Aging and National Institute of Health. They have a website together that has a bunch of resources.
Okay. Thank
And you
you.
can just search their materials, their print materials. Okay. Any other questions? Okay. So I wanted to talk briefly about trauma as another factor in cognition. So having a trauma history has been linked to cognitive impairment. Having PTSD or post-traumatic stress disorder makes it more likely someone will develop a neurocognitive disorder as well. So these associations have been found. It's important to note that they haven't yet been able to show that the relationship is causal. So it could be that, folks who have trauma, who have PTSD, there's also an association with more substance use. And that is kind of playing into developing a neurocognitive disorder. So just important to keep in mind that it's not necessarily a causal link, but there is an association. Okay, and just a couple of things that that may be signs to look out for that someone may have PTSD or have a trauma history, even if you're not aware of it. And this is any trauma history, not just military trauma, but it could be childhood trauma. So if you're seeing someone's having frequent nightmares, that can be a sign that there is some trauma history. If they're having agitation or showing like a fear response or increased anxiety when they're faced with certain things, specific cues, that may be another sign that we need to think about PTSD or a trauma diagnosis. And so when I've seen this most often, when I was working in nursing homes, is anniversaries. So, if someone experienced a traumatic event, around the holidays, maybe the holidays are really difficult. Holidays by themselves can be one of the times a year that folks have a lot of trouble. 4th of July and New Year's with all of the fireworks is usually one of the ones that folks who have PTSD really struggle with. And then environments that are crowded or like overstimulating, too much noise can be another trigger. Okay, and I think this is where I'm going to be shifting to another topic. So let me pause again for just a second and see if you all have any questions or comments about dementia diagnosis or about these risk factors that are unique to a veteran population.
I do want to highlight in the chat that Stephanie Hart's included the dementia guide that's specific for veterans, and it's very family friendly. So that would definitely be a good handout for your patients that are veterans and have dementia.
Mm-hmm. Thank you for doing that, Stephanie.
You're welcome. I'm here in the background.
All right, perfect. Okay, so for the rest of the time, what I want to focus on is treatments that are relevant to end of life, given that you are a hospice partner audience.
And
like
a quick question. I'm sorry.
Yeah, no, you're fine.
I have a little bit of background noise. You mentioned that dementia can show up in different ways, and depending on like if it's a psychiatric issue or just cognitive decline. Do you treat it differently? It might be presenting the same way, but does it? You said sometimes you don't know which is causing kind of what appears to be a lack of inhibition or executive functioning decline or those kind of things. Does it change how you treat it?
Yeah, so if I am not sure if it's mood or sleep or pain or some other factor that's contributing to the changes in cognition, the first step, usually my recommendations are let's treat those things first. And then once they've improved, let's do some more testing. So if you test again after the mood's improved and the sleep is better and the pain is controlled, you should be able to see what's left. So have the cognitive impairments gone away, or are we still seeing something? And so that can give you a good idea of what is due to an actual neurodegenerative process, something going on that we're not going to be able to, treat with therapy and medications. That's
So
a
there
really good
could be a
question.
case where somebody's PTSD causes a lack of sleep and they present with dementia, but after the PTSD is treated and the sleep is better, the dementia symptoms might not be present anymore. Am I understanding what you're saying?
Yeah, usually in my experience, it's in the more mild range that I see, there's a bunch of factors at play. The deficits are not really, really severe. So it could be one of those other factors. When you're seeing, really severe impairment, if you treat some of the factors, what I would expect is you may see some improvement, but it wouldn't totally go away. So if someone is experiencing that severe of cognitive impairment, that's usually not just because of mood or just because of pain. Does
Thank
that make
you.
sense?
Yes, thank you.
Yeah, of course. Good questions. Okay. So I just want to put in a plug for the information I'm going to share with you is all from a book chapter that I helped co-author. And so the chapter was focused on behavioral management of some of the physical and psychological symptoms that we see in palliative care. And I wanted to recognize my co-authors, so Dr. Ann Horgus and Dr. Tony Glover in Florida. And so we're just going to talk about some of the more common symptoms we see at end of life, and then some of the ways that we researched treating those symptoms behaviorally. And so this slide is just really talking about when we're thinking through different interventions that we might want to use. Of course, I'm always an advocate for both pharmacological and non-pharmacological methods. I think especially in older populations, you may find folks who are really more interested in behavioral interventions. They're taking 30 medications and they really just don't want to take another one. So is there a way that we can try to treat these symptoms with something other than medication? And then I think it's also really important to work on a plan that is focused on their goals. So a person-centered treatment plan. Are they wanting to be as pain-free as possible, even if that means they are less able to interact? Or is it more important that they're able to talk to their family and friends, even if that means their pain level is going to be greater? And so their priorities and goals, of course, lead to different treatment plans. So it's important to consider that. And also, I think their cultural background is important. Excuse me. So, do they have a strong religious community and they want a faith leader involved, or do they really want family involved, or do they really not want family involved? And so having some of those discussions early on, I think, can really help guide how we approach some of the symptom management. So this is a really, really busy slide. As you can see, there are lots of methods that we can use to manage symptoms. And so I want to just briefly look at each one and tell you a little bit about them. I think for everyone that I've included, I've had experience with these, seen them, being used. And I think it's important too to keep in mind, I'm just presenting a summary of the research, for each one. So I'm trying to give you sort of the broadest overview of, the symptoms that these different interventions have been shown to be helpful, but keeping in mind that not every strategy, is going to work with everyone. Okay, so the first is acupuncture. And I'm sure you all have heard of acupuncture. It's often considered a part of complementary medicine. And it's stimulating different parts of your body by inserting those thin needles into the skin. The most consistent evidence for acupuncture has been in treating pain. And this is often used in conjunction with the TENS units. And it has been shown to be really effective when those two are used together. But it's also been shown to improve shortness of breath, oxygen saturation, 6-minute walk distance, quality of life, experiences of nausea and fatigue, and even dental pain. So it's important to note that for acupuncture, it does have to be performed by a trained practitioner, but definitely one option, especially if pain is one of the primary symptoms. Okay, and then massage. This is one that I think it's important to kind of put out that disclaimer. There's going to be varying levels of comfort depending on the relationship between the caregiver and the person who's receiving the massage. I think of this one as something that can be really helpful for like family members, close relatives to use if they are comfortable. But massage on its own has been shown to be effective at relieving pain. It's also been associated with reduction in symptoms of anxiety and depression. And then you can see a few others listed that have been mentioned in the literature out there. I think with massage, the thing about massage that's sort of a drawback is we're not real sure about the frequency. So how often and the duration that's needed to be most effective. So how often are we needing to use massage, and how long should the massage be to have the best outcome? So another area where some more research would be really helpful. And then aromatherapy, one of my favorites, another form of complementary medicine. And this is using essential oils or plant compounds with the idea of helping to improve their health or mood. Typically, when we see aromatherapy in the literature, it's combined with something else like massage or music therapy or something like that. It has been shown to alleviate mood symptoms and pain. I think that this is one of the ones where you're more likely to see a short-term benefit than a longer-term benefit. So massage is the same way. You know, you're expecting to see benefit right then as you are doing the massage or as you have aromatherapy in the room, but not the longer term benefits that we see with some of the other interventions. I did want to mention when I was working in palliative care before, one of the things that we used that I thought was really cool was they have patches. You all have probably seen these aromatherapy patches. That you can put them on clothes, like on the person's clothes. They were pretty strong that way, but you can also kind of put them right behind the bed or, you know, on a wall nearby. But I thought that those worked really great to provide some aromatherapy in that setting. Okay, so when we talk about therapeutic touch or healing touch or things like Reiki, this is one of the areas where the research is really equivocal. So we see about the same amount of research that says, yes, this is helpful, as we see that says, no, it's not really helpful. So we need more research, but there have been some studies that found that the use of therapeutic touch was helpful at improving sleep or increasing relaxation. It's been used to treat anxiety and fatigue and to improve quality of life. And another important note is that it's not necessarily actual physical touch. So it may just be hands near the body, more of like energy work. So when we think about Reiki, they're not actually touching the person usually. But the intention is to just help relax, relieve pain, and promote healing. I apologize for the sniffling today. I've got some allergies. Okay. So environmental control, when I say environmental control, I'm really talking about ways to modify the environment that are going to help promote positive physical and mental health outcomes. And so this is really helpful, particularly managing delirium and dementia. So there's less consistent evidence for just your more general palliative care population, but especially in folks who are struggling with dementia or delirium. And this can be the sound in the room, the temperature. It can be what type of furniture is in the room, the lighting levels, both in the room and like the hallway can be important to consider. And so the goal is to really have a calm environment where the person feels safe. As much natural lighting during the day as possible is really helpful. And then, a darker space with less noise and stimulation at night. Those are really important to help with some of the disorientation that can happen. This can also include just having access to any assistive devices, like if the person has a walker, being sure that the walker is where they can reach it. And then just using orienting materials. So I love it when I walk into an inpatient room and there's a big board that has the date and it has, who their provider is, their name, and anything that they have going on that day. So helping them kind of keep track of what's going on. And I think a really important piece of this is that providers are educated on the appropriate use of these different types of environmental controls because they're the ones that are putting this into place. So knowing that the natural lighting is helpful and being sure to really differentiate day from night is helpful. And when that type of education happens, it leads to improved outcomes for both the patients and also the providers because it helps reduce some of those symptoms we see. And so some of the possible indications we've talked about, dementia and delirium, also sleep difficulties and mood. I'm just checking our time. I'll try to go quickly through the last few. So snoozolin, I'm not sure if you all have heard of this. It's one of my other favorites. It's multi-sensory stimulation where light and smell and sound and taste are all used to stimulate the person. And so some facilities do this by having a room like you see in the picture here that's dedicated. So you can take someone into the room. They usually have, I'm thinking to the room we had in the CLC where I worked before, they had some of those pillars with water. So there were like bubbles and lights. They had a projector that would project images on a big wall. They used aromatherapy as well, and they had some sensory toys like balls and different things with different texture. And they were playing some music in the background. So those rooms are really immersive and wonderful. But we also had, folks who weren't able to get to the room. And so there were, you can make a cart that's kind of similar that has more mobile versions of those things so that you can take it around to the patients who are bedbound. And so the use of snoozolin has been shown to decrease anxiety, to improve mood in patients with dementia, and just to improve daily functioning overall. So art therapy and music therapy, pretty self-explanatory. They're encouraging, expression through art. So using that creative process of making art as a way to explore and improve their own mental health. And then music therapy is using different facets of music, like spiritual, emotional, physical reactions, again, to try to help individuals improve their mental and physical health. And so the research that's out there has found improvements in pain and fatigue and nausea, depression, anxiety, well-being, some reports of subjectively improved relationships. And that was all after a single session of art therapy. So low dose requirements. Oh, I'm sorry. There we go. Are you still seeing the art therapy slide? Yeah, okay, perfect.
Yes.
And then for music therapy, it has been shown to be helpful in reducing pain, fatigue, anxiety. It's been shown to improve mood and spirituality, and it's effective at reducing agitation in patients with dementia. I know when I was working in a CLC before, there were some patients that I would see who, we just couldn't really communicate verbally as much. And so I used music quite a bit just to sit with them and have something pleasant that we could do together. Animal assisted therapy. So this is traditionally an interaction between like a highly trained therapy animal and the animal's handler and then the patient. Again, with the goal of improving mental and physical outcomes. So it's been used to treat pain, severe mental illness, and other mental health conditions. It's been shown to reduce anxiety, depression, fatigue, stress. A couple of important notes. If you're going to use animal assisted therapy, it is important to screen for phobias. Make sure they don't have a phobia to the type of animal. Thinking about allergies and any other contraindications. And then I also just wanted to mention the bottom two pictures. Those are robo pets or robo animals. And so when live animals aren't feasible for whatever reason, the robo pets can be a really nice alternative. We use these in our locked dementia unit quite a bit with a lot of success. And then for one of the veterans that I've seen pretty recently, he has early onset Alzheimer's and they have a cat at home who he loves very much. But as his disease is progressing, he really wanted to have the cat with him all the time. And the cat was not on board with that plan. And so he was getting scratched up quite a bit. So I talked with the wife about getting him a robo pet, which she did. And now he carries his robo pet around and it really worked out great. So the poor kitty got some relief and he's still very happy with his robo pet. So, okay, guided imagery and hypnosis. So this is using either music or directing someone's thoughts or suggestions. The goal is to bring someone into just a relaxed, focused state. So you could have them visualize a starry sky or a beach or a forest, something like that. And then just a note on hypnosis. So as psychologists in the VA, we have to be trained and certified to use hypnosis. And they call it something different. It's not just hypnosis, it's the use of hypnosis to kind of bring about improved outcomes. But it is helpful, especially when it's used together with other therapies, like someone who's wanting to quit smoking. So you could use hypnosis along with therapy to quit smoking. And so it can be very useful for health behaviors. It can be useful to reduce pain and has also been helpful in treating anxiety and nausea and vomiting in palliative care populations.
There was a question, Christy, just, do you know if
Mhm.
there's an organization that helps makes robo pets affordable and available? Do you know of anything?
I mean, I know that the prices vary when you look online, but generally speaking, you're looking at about $100. As far as I know, just from a VA perspective, outside of being able to order them for inpatient work, I don't know of a way to make it more affordable for outpatient families who are wanting to get one. That's a really good question. I wish I had an answer that was yes. Okay, I'm gonna go quickly through the next few. I believe you all are getting these slides, so you can review them and always reach out if there other questions. So meditation and relaxation, this is again to try to help kind of slow down the mind, help the person become more calm in a focused state. It's really useful for treating anxiety or stress. It can also be helpful for treating shortness of breath related anxiety, in addition to like the pursed lip breathing or a fan, like blowing air across the face. And then meditation, again, is very useful. For both of these, I would say it's important to understand that you have to practice these things. So typically you get greater and greater benefit the more you practice, the more you use them. Okay, so Tai Chi and other types of movement related therapies, again, very useful, especially for pain, fatigue, stress, sleep. For this one, it's just important to really be aware of mobility restrictions. You want to be careful in folks who do have dyspnea, and if they have cognitive impairment, just being sure that it's an appropriate treatment. Psychotherapy, this is useful if you're if you have someone who can engage in kind of more intensive treatment. So usually psychotherapy is 12 to 16 sessions. And it can be really helpful for any type of mood or emotional distress. And it can also improve physical symptoms as well. So two of the main types that you'll hear about are cognitive behavioral therapy and acceptance and commitment therapy. I'm sorry. And again, important to think about the person's cognition. So for traditional therapy to work, the person has to be able to track from session to session. So we're building on the previous session every time we meet. And there's usually some type of, homework or assignment in between sessions. So the person has to be able to kind of keep track of that and carry that information across time. And then spiritual or religious-based interventions. The research that we looked at, I thought was really interesting here, because the majority of people who receive palliative care say that they do have concerns about their spiritual well-being, but only a minority report that those concerns are addressed in any way. And, I think that's probably due to a number of factors, provider comfort, just not having enough chaplains. But this is an area where I think we could definitely do a better job of addressing some of the needs of our patients. And then I just have a note about the difference between spirituality and religiosity. Okay, since it's 5 till, here's my summary slide. These are all the things I hope that we talked about and learned today. I wanted to give you my email and my office number in case you have any questions. I do have a reference slide at the end with some resources if you're interested. And that's all I've got. So any questions or thoughts?
Great. Thank you so much, Dr. Christie. Are you able to stop your share and then we can see everybody and see if there's any last moment comments or questions? Oh, my video's still off, sorry. This is really helpful information. I don't know if you're familiar, you probably are, with Healing Warriors. We've had them speak to us before, and based out of Fort Collins, but they go and have some on-site treatment days. I think one in Denver. Have you heard of them before?
I haven't.
They do acupuncture, healing, touch, and craniosacral for
Nice.
veterans, for veteran spouses, for active
Mhm.
military members and their parents.
Oh, that's awesome.
So yeah, really awesome organization.
Yeah.
Any questions? You have a lot of knowledge and experience. Really appreciate you sharing your information because that's helpful. There,
Yeah.
I'm sure will be follow-up questions.
Absolutely.
Do you have
Yeah.
any kind of last, we work with veterans at end of life. Is there
Mhm.
anything, if you thought you could use one modality that might really help a veteran with dementia be more comfortable and at peace? You shared a lot of different modalities. A lot of us work with volunteers. Is there anything you especially recommend? Or if we recruited volunteers who could do the specific thing, what might that be?
I think because individuals vary so much in their history and their presenting primary symptoms, it's really hard to say that one thing is more helpful than another. I think the kind of the thread that connects all of these is sort of your own like your own presentation and approach. So whichever intervention you're using, especially folks with dementia, they really look to our posture, our tone of voice, our facial expressions. So I think it's really important, whatever you're doing, that you're calm and collected, you're in a good space to be delivering the intervention. And I think that makes a big difference, no matter what it is you're doing to try to help. But a lot of times my experience has been that just the presence, having someone there who actually cares and is taking the time to try to give a little more help, that's really meaningful and powerful.
And have you seen some veterans with dementia go back to that place of their 18, 19-year-old, 20-year-old self into the space where they might have been serving or have high
Yeah.
fear or things like that?
Yes. And I've seen them go back to even younger. We had one who I think he was thinking he was 7 or 8, and every morning he wanted to get ready for school and was looking for his mom. So yeah, it really varies. And I think for those types of situations with him, we would, tell him that his mom ran to the store and she would be back soon. And we even tried giving him like worksheets and things that he could mess with because that's what he thought he should be doing with schoolwork. For the ones who are kind of more stuck in their military days, sometimes it was helpful to refer to them by their rank or their title, and just having kind of a more formal way of interacting, especially I saw with the officers, that seemed to make them comfortable, like feeling like they had that control again. But again, it really varies. It depends on, their experiences in the military. Were they really positive? Were they not so positive?
Well, thank you so much. It's noon. You have a couple things in the chat just saying great presentation. Thank you so much.
Thank you. Thank you. Thank you. Thanks
Appreciate
for
your
having me.
time.
Yeah.
Thank you, Laura, Madeline, and Stephanie for lining this up. And I hope everyone has, a happy new year. We'll see each other next year. So
Merry Christmas. Happy New Year. Thank you so much. That was wonderful.
Thank you, everyone.
Thank you,
Great.
guys.
Thank you. Take care.